Hello, everyone. I'm Kevin Fung from Hong Kong Children's Hospital. I am a pediatric interventional radiologist who joined this hospital 3 years ago. And we treat mainly children with oncology and renal vascular disease here. So in this paper, we describe a case of high-flow aneurysmal renal arteriovenous fistula, and which was successfully treated by embolisation using a transarterial and transvenous approach, deploying coils in a pediatric patient. And this 13-year-old girl first presented to our hospital with hypokalemic hypertension, and her CT showed a massive arteriovenous fistula involving the renal hilum. At that time, 3 antihypertensive agents were required to control the blood pressure. And since the arterial supply of the arteriovenous fistula is entirely incorporating the renal hilum, at first the pediatric surgeon suggested total nephrectomy, so to remove the kidney en bloc for the patient. But however, after multidisciplinary discussion and talking to the parents, we decided to proceed with endovascular embolisation in order to preserve as much kidney as possible. High-flow AVF is technically challenging to treat as embolics are easy to migrate into the venous system due to the hyperdynamic circulation. In our case, the large size of the aneurysmal fistula makes it even more tricky because it's difficult to achieve a satisfactory coil volume with just 1 to 2 coils. And this was actually demonstrated in the start of the case, where one of the coil deployed transarterially prolapsed into the inferior vena cava, and we had to snare it out and remove it. And after which we cannulated then both arterial and venous side and deployed large volume coils simultaneously, and this allowed us to achieve a stable coil mass quick enough to prevent migration of the embolics into the venous system. And ultimately, it took us 19 coils and a bit of NBCA glue to achieve a satisfactory occlusion of the fistula. And a small wedge of renal parenchyma has to be sacrificed, but most of the kidney was preserved, and the blood pressure and potassium level returned to normal, back to normal for the girl, and she recovered uneventfully. And I think this paper shows that the simultaneous deployment of coils through artery and vein serves as an alternative to a more traditional flow control strategy, such as using a proximal occlusion balloon that's more commonly described to treat this kind of high flow aneurysm. The potential issue of using a flow control balloon in pediatric population is that the catheter usually is a larger size, so it requires a larger femoral sheath, often up to 8 French. So this is not ideal for patients with small femoral artery. This case showed our clinical colleagues that embolisation is actually a good alternative to traditional approach for this kind of large size aneurysmal renal fistula, which often means a total nephrectomy for the patient in a more traditional thinking. And in our locality in Hong Kong, the discipline of IR is not as well established as other parts of the world, such as Europe or UK or US. Pediatric IR is particularly under-recognized as well. So this case certainly showed our pediatric nephrology colleagues and our pediatric surgeons the value of IR in management of complex renal vascular diseases. So the clinical benefit is clear for the patient in this case. After the procedure, she was soon be able to move around with just a small femoral wound, and she experienced minimal post-procedural pain, and antihypertensive medication was being taken off with a normalization of blood pressure. And most importantly, she can still keep both kidneys. She didn't have to live with a huge scar or losing one kidney, which is important for children as they have a much longer expected lifespan than adults. And the child is now hypertensive free, and she and her parents are much happier as they no longer worry about carrying a ticking time bomb that may rupture at any moment.